Hello, my name is Aisha Domingo, and I am a third-year Doctor of Pharmacy candidate at Florida A&M University. And I did my journal club presentation today on a trial titled "A Randomized Trial of Intra-Arterial Treatment for Acute Ischemic Stroke." The authors that participated in this trial and the citation is included in the journal club form provided to you. The trial was funded by the Dutch Heart Foundation and others. So the background, intra-arterial treatment for emergency revascularization is highly effective to those patients with acute ischemic stroke that is caused by occlusion in the proximal intracranial artery. However, there's a lack of proof on whether or not this treatment alone is effective or beneficial to the overall functional outcome of the patient. The methods, so the objective was to determine whether or not the intra-arterial treatment with the thrombolytic therapy, such as alteplase or tenecteplase, was beneficial as opposed to just using thrombolytic therapy alone in patients with acute ischemic stroke. The trial design, it was pragmatic, phase 3, randomized. It was an open label treatment, so both the patient and the physician knew about the treatment. And it was blinded. It was a blinded endpoint evaluation. The location, it was a multi-center trial, and it occurred at 16 centers in Netherlands. The IRB approval was the Mr. Clean investigator. The inclusion, so you had to be equal to or greater than 18 years old and had to be able to initiate an intra-arterial treatment within 6 hours after the onset of a stroke. Patient had an occlusion of either the distal intracranial carotid artery, the middle cerebral artery, or the anterior cerebral artery. Inclusion of patient who had an additional extracranial internal carotid artery occlusion or dissection was left to be decided by the treating physician. The exclusion, so the trial didn't really provide the exclusion of this. The journal didn't really provide the exclusion of this trial, but since they had to be 18 years or older, so they couldn't include anyone who was less than that age, which is 18. The subject, so they had to be 18 years or older, and they had to have had an acute ischemic stroke that was caused by an intra-arterial occlusion in the anterior circulation artery. The primary endpoints. So the primary endpoints included. They used the modified Rankin scale at 90 days. And a 7-point scale measured by a score ranging from 0, meaning no symptoms, to 6, meaning death, and a score of less than 2 indicated functional dependency. The secondary endpoints were the NIHSS, which was the National Institute of Health Stroke Scale, and they scored this at, it was like a 24-hour score, and at 5 to 7 days, or discharged if earlier. So they did a score within that range. So it's at 24 hours or at 5 to 7 days, or if you're discharged before then they'll do that score. The ADL, which is activity of daily living, was measured with the Barthel Index. The health-related quality of life was measured with the Eurocore Group 5-dimensional self-report questionnaire at 90 days. So this is just a standardized instrument for measurement of the health status, and the test ranged from 0.33 to 1. When you have a higher score, meaning that you have a better quality of life. And the other secondary endpoint was the imaging outcomes, which included the arterial recanalization measured with the CT or the CT scan or MRA at 24 hours, and a final infarct volume on the non-construct CT at 5 to 7 days. The follow-up, so they had the follow-up interviews were done at 90 days by a single experienced trial investigator who was unaware of the trial. The interview was conducted via phone with the patient or the healthcare provider. The duration of the trial was 90 days, and the population, they had 502 patients, but 2 of the patients had to drop out. 2 of the patients dropped out, but they were still included in the trial. that they're still included as part of the number of patients in the trial, even though they dropped out. The arms, they had the intra-arterial treatment, which was arterial catheterization with a microcatheter to the level of occlusion and a delivery of thrombolytic agent or both. And then they had the thrombolytic therapy, which in this trial they used alteplase or urokinase. Statistical analysis. It was based on the principle of intention to treat. The primary effect variable was that adjusted common odds ratio for a shift in the direction of better outcome on the modified Rankin scale. The ratio was estimated with a multivariable ordinary logistic regression. The adjusted and unadjusted common odds ratio were reported with a 95% confidence interval to indicate statistical precision. Treatment effects modification was explored in pre-specified subgroups of patients defined by, they have the NIH score. So you have 2 to 24, or 6 to 19, or more than 20. The age, you have either greater than 80 years old or less than 80 years old. Occlusion of internal carotid artery. Treatment associated, yes or no. Additional extrakinal internal carotid artery occlusion, yes or no. Time from stroke onset to randomization. So this was measured in minutes, less than 120 minutes or more than 120 minutes. And then lastly, the aspect. The aspect, which is a score that measures the extent of the stroke. The score ranged from 0 to 10, with the highest scores indicating fewer early ischemic changes. Scores were not available for 4 patients assigned to the control. The results of the baseline characteristics. The 500 patients that are randomized, they had 221 patients. That was approximately 46.6% who were assigned to the interventional group. The interventional group was this group that received both the intra-arterial treatment, like the intra-arterial treatment plus the thrombolytic therapy. And they had the 267 patients who were assigned to just the control, which is just like the usual care only, which is just like the thrombolytic therapy only. The results in the primary endpoint, the modified Rankin scale showed a shift in the distribution of the primary outcome in favor of the interventional. They had a shift towards better outcome in favor of an interventional, which was consistent for all categories to the modified Rankin scale, except for death. The results of the secondary endpoint, they also favored the interventional group. The NIHSS score after 5 to 7 days was 2.9% lower on average in the interventional group compared to the control. Data on the recanalization after 24 hours were available for 394 patients. An absence of residual exclusion at the target site was more common in the interventional group, which was 141 out of the 187 patients. The data on infarct volume were available for 298 patients out of the 500, which favored the interventional group. The good reperfusion was achieved in 115 patients out of 196 patients in the interventional group. The adverse effects, they really didn't have no significant difference between the two groups. However, they did have like a new ischemic stroke at a different vascular region occurring within the 90 days, and they had 13 patients in the interventional group who had this, and only 1 patient in the control group who had the new ischemic stroke. Complications related to the procedure in the interventional group included embolization in a new region and 20 patients. It happened to 20 patients, and then also had procedure-related dissection for patients, and they had the vessel perforation in 2 patients. And this is all only in the interventional group and none in the control group. So the ethics conclusion. So the conclusion was the treatment of acute ischemic stroke caused by proximal intracranial occlusion of anterior circulation with intra-arterial treatment is safe and effective when administered within 6 hours after onset of the stroke. The strength of this trial, it had consistent baseline characteristic. It was a strong study design and had a long period of randomization. Some of the weakness, he had a small sample group, it was only 500 patients. The randomize was slightly unbalanced. They had the 2 patients who had dropped out because of due to the randomization. The reproduction rate in the trial was relatively low. It was 58% compared to other trials rate, which was like 80% or higher. And almost 90% of the patients developed a new vascular region. Patients were also aware of the treatment group assigned to them because it was that open label trial. Both the patient and the physician were aware, so it was kind of like biased. Alright, so a little bit of summary. So in conclusion, the study proved that the best treatment for acute ischemic stroke caused by proximal occlusion is the intra-arterial treatment. It is the safest and most effective way to manage the patient. The treatment leads to a clinical significant functional daily life increase by 3 months without any increase in mortality. My conclusion, despite the treatment being a better option in this patient, they did have a lot of adverse effects compared to just them using the thrombolytic therapy. So I will be a little bit hesitant to recommend this product. There was no significant difference in mortality between the control group and the interventional group, so there's really, in my opinion, there's really no benefit of using the intra-arterial treatment and risking all those adverse effects and the adverse effects when the mortality difference wasn't really, it was pretty similar. There was no difference. Also, the score that indicated the better quality of life, which was the EQ50 score, it was pretty similar. The controlled group had, I believe, they had scored a score of 0.69. That was the intervention group. They had an EQ5D score of 0.69, and then the control group had a 0.66 point of the EQD. So it's pretty similar compared to when you compare those two. And that's it. Thank you.